Hi, everybody. Thanks for joining us today. We're just going to give it another minute or two for people to join us. All right, we'll start in 1 minute, 12:01. Okay, all right. Well, thank you everybody for joining us today. Today we will be focusing on delivering protection, maternal vaccinations for RSV in pharmacy and obstetric practices. So just a couple of housekeeping right before we start. So all lines are muted during the program. We do have a question and answer box that you can find the bottom of your Zoom that please feel free to ask questions there. This webinar will be recorded and posted to the California Immunization website, which has a link to the YouTube page. So you will be able to watch the program afterwards. Next slide. And we like to thank all of our sponsors, including the California Immunization Coalition, the California Academy of Pediatrics, and California Pharmacists Association, as well as CDPH. So I am Pia Pannaraj. I am a professor of infectious diseases at UC San Diego and Rady Children's Hospital, and current president of the California Immunization Coalition. And I'm joined by my co-moderator, Eric Ball, who is the vice chair for the American Academy of Pediatrics, California, as well as the vice president of the California Immunization Coalition. So I'm going to turn it over to Eric.
Thanks so much, Pia. We have a really exciting webinar for you today with two excellent speakers. So I wanted to just give them a brief introduction. So speaking first will be Dr. Neil Silverman. He is a clinical professor of obstetrics and gynecology at the David Geffen School of Medicine at UCLA, and an expert on pregnancy and obstetric infectious diseases. He's been named to the perinatal point person for the California Department of Public Health to answer questions related to Zika virus. He's a member of ACOG expert work group on immunization, infectious diseases, and public health preparedness, and serves on the advisory council of the California Immunization Coalition, as well as the Society for Maternal Fetal Medicine's Committee on Infectious Diseases and Emerging Threats. And joining Dr. Silverman is Dr. Richard Dang, who is an assistant professor of clinical pharmacy and the program director of the community-based pharmacy residency program at the University of Southern California. So we have UCLA versus USC today working together. He is also the immediate past president of the California Pharmacists Association and vice chair of the Immunization Coalition of Los Angeles County. He's an advanced practice and board-certified ambulatory care pharmacist with expertise in immunizations, travel health, and community-based pharmacy practice and health programs. He's the past president of the California Pharmacy Association, the vice chair of the Immunization Action Coalition of Los Angeles County, and on the board of directors of our California Immunization Coalition. And with that, I wanted to turn this over to Dr. Silverman to start the webinar. Thank you both so much for joining us.
Okay, thank you, Dr. Ball, and thanks to everybody involved in this webinar. I am going to start off with a brief overview on what we're here to talk about, which is RSV in infants. RSV is still the leading cause of hospitalization in the United States for infants. Most of these infants, over 2/3, are infected in the first year of life, and almost all of them are infected by 2 years of age when they are this ill. Overall, about 2 to 3% of infants will be hospitalized for RSV, and it is a very common cause of not just hospitalization, but lower respiratory tract infection in infants as we enter our respiratory virus illness season this month. About 80% of children who are hospitalized with RSV infection under the age of 2 have no underlying medical conditions. And as you can see, there is a pyramid of severity of impact on children, their families, and the public health system. So every year for kids under the age of 5, RSV is associated with up to 300 deaths, up to 80,000 hospitalizations, a little over 500,000 ER visits, and 1.5 million outpatient visits. And this graph from the CDC emphasizes that the majority of these hospitalizations occur within the first 2 months of life in our infants. What we're here to talk about today is how active immunization of pregnant patients as well, which is a little bit different for RSV, active passive immunization of newborns can protect infants in the first few months of life. This is a concept we've been working with for any number of years for other illnesses related to respiratory infections. So, for example, we give Tdap routinely in pregnancy. We give it to the mother not to prevent her illness, but to transfer maternal antibodies to the fetus and still have them in the newborn system after birth to protect infants and newborns against pertussis. That is similar to the way RSV vaccine is designed to work with passive transfer of antibodies. We also encourage, just to remind folks, active immunization of mothers against COVID and influenza during respiratory season, both to protect the pregnant patients who are more severely affected with these illnesses, as well as to transfer antibodies from the mother to their at-risk newborns to lower their risk of illness and to mitigate the severity of their illness. So with that as an introduction to lead us into why RSV vaccination is now being reinforced now in the second season of available interventions, Dr. Dang will take over.
All right. Hi, everybody. Thank you, Dr. Silverman, for the background and the introduction. So let's get started and talk a little bit about some of the RSV vaccines and a summary of the recommendations and clinical data. So how did we get to where we are today? So just to level set the timeline, we are entering the second season of availability for RSV vaccines. And as you take a look at the slide, you can see some of the key dates in which the various vaccine products or monoclonal antibodies received FDA approval and or ACIP recommendations. For those of you who've been involved in RSV vaccination over the last season, you're probably familiar with some of the timeline from 2023, but there was a flurry of activity around RSV vaccines surrounding older adults over this most recent summer in 2024, so as well as the addition of a new approval for a third RSV vaccine product. So as we take a look at that timeline, we can transition over to the 3 main populations where RSV vaccine or vaccine products have a recommendation. So our first group is our older adults aged 60 years and older. There are currently 3 vaccines that have an FDA approval and ACIP recommendations for use in that target population. And then second being pregnant persons with 1 RSV vaccine product with approval and recommendations in that population. And then third being our newborns and our infants, and that's actually with a vaccine product that is a monoclonal antibody. Now, today's focus is specifically on the pregnant persons and the newborns and infants, so we will not be discussing the recommendations for older adults. But as we take a look at our two focused target populations for today's webinars, pregnant persons, there is one RSV vaccine, which is the Abrysvio product, which is recommended for use in that target population. And then for newborns and infants, there are two monoclonal antibodies, nirsevimab, which is the Beyfortus, and palivizumab, which is Synagis. However, palivizumab has a very targeted and narrow indication. That's the product that's been around for several decades, so it's not as widely used. Whereas nirsevimab is the newest monoclonal antibody that's become available over the last year, and that is the one that has a universal recommendation for our newborn and infant population. So just to take a look at the highlights of our ACIP recommendations for protecting our newborns and infants, there are two pathways in which we can confer protection to that key target population. The first pathway is through maternal vaccination, as Dr. Silverman had reviewed in the background. With that particular target population, it is recommended to administer one dose of an RSV vaccine, and currently only Abrysvio is approved for that population, at 32 to 36 weeks of gestation during September to January. And we'll talk a little bit more about the months and timing of the vaccine administration in a future slide, but the timing of the vaccine product during the year is going to be an important consideration. Now, the other pathway to give immunity to infants is through passive immunization with our monoclonal antibodies. And so for those infants who are aged less than 8 years with no history of maternal RSV vaccine, they can be administered one dose of nirsevimab after birth or prior to entering their first RSV season from the months of October to March. There is a second population of infants who may also receive RSV and monoclonal antibodies in their second season, but that's going to be a targeted, focused population of high-risk infants. So as we take a look at these vaccine recommendations, it's one or the other. So again, it's either going to be protection through maternal vaccination or protection with administration of a monoclonal antibody. In most cases, we're not administering both of these products to our infants and newborns to offer them protection. So it's just to hone in on some of the key considerations for selection of product, timing of vaccine administration, and number of doses. So as far as selection of product, we mentioned this already, but essentially for pregnant women, the maternal vaccination, only Abrysvio is currently approved for use in this target population. So we do want to be cautious to choose the correct brand. As we mentioned earlier, there are 3 RSV vaccines, Arexvy, Mrezvia, and Abrysvio, that are currently on the market. Those are for our older adult populations and recommendations. But again, for pregnant women, at this time, it is just Abrysvio. And one fun way to remember this is Abrysvio has a B in it. And when you think about the B, it looks like a pregnant woman's pregnancy bump. So that was one fun way that we kind of teach our students to memorize which product is recommended in this particular population. Now, when this product came on the market, there was a lot of concern about potential misadministration of the vaccine. And when the CDC took a look at some of the VAERS data over the last year, the good news was that the magnitude of errors wasn't that large. So for the misadministration of the incorrect dose, there are about 128 reports for the wrong RSV vaccine product that was used in pregnant women. So that's a pretty small amount compared to the millions of doses that were administered in that population. The other key thing that we talked about is, again, choosing only one of the pathways, maternal vaccination or monoclonal antibody. And when the CDC reviewed some of those errors, they did found that there were 25 errors reported in that infant population where maybe they've received the monoclonal antibody when it wasn't necessary because they had already received antibodies through maternal vaccination. So the point here being, be very careful if you are administering vaccines for the pregnant persons or for the infant to double check to make sure that you're choosing the correct product that is recommended for that particular population. The second consideration to keep in mind is the timing of the vaccine. So we do know that RSV season typically peaks around December to February, follows a very similar seasonal pattern to influenza in the winter seasons. And so for that reason, CDC makes some recommendations on when RSV vaccine or nirsevimab monoclonal antibody should be administered to their target population in order to maximize protection during the peak of the RSV season. And so as you look at this graphic here, summarizing some of those dates, the pregnant woman who is at 32 weeks to 36 weeks of gestation during the months of September to January can receive an RSV vaccine. And then for an infant who's born from October to March, they can receive a monoclonal antibody. For any other months outside of that time frame, from April to August or April to October, depending on the population you're talking about, for those time periods where there are no recommendations, you would wait till October to administer a monoclonal antibody for the infant. So that's one of the key considerations is what time of the year are we in, and is it appropriate to vaccinate, or should we wait? Now, with that being said, there are some areas of the United States where the RSV season can vary. And so there may be times where your local Department of Public Health will issue advisories on when that is going to be. And so they may issue real-time recommendations on the changes to which months may be appropriate to do maternal vaccination or monoclonal antibodies. So you should pay attention to some of your local health jurisdictions' recommendations, especially if you're in Alaska, Florida, or outside of the continental United States. Then the other additional consideration is the number of doses. So as I mentioned, this is the second season now that we've had RSV vaccine available on the market. So this is somewhat of a new discussion for us to think about. Because the vaccine is new and due to limited data, the current recommendation from the CDC is that pregnant women should only receive a one-time lifetime dose of RSV during their pregnancy at this time. So what that means then is if you have a mother who is returning for a second pregnancy during this year, if they've already received RSV vaccine during the previous calendar year, for this current calendar year, they should not receive an RS vaccine due to the lack of safety and efficacy data available for us at this time. So what that would mean then for this particular mother who's entering their second pregnancy during the second RSV season is that instead of maternal vaccination, we would opt for administration of monoclonal antibody to their newborn infant if they're born during the appropriate time frame. Now, this doesn't mean that this might not change in the future. As more data becomes available, the CDC will evaluate that, and that they may make recommendations for subsequent doses for future pregnancies in the future. But again, at this time, it is just a one-time dose recommendation for this target population. As far as the monoclonal antibody recommendations, on this slide, we have the summary of those infants who should receive it. On the left-hand slide is all of our neonates and infants less than 8 months who were born during or who are entering their first RSV season. So again, those are infants who were born to mothers who did not receive an RSV vaccine, or infants who were born to mothers with an unknown vaccination status, or infants who are born to mothers within 14 days of maternal RSV vaccine. And that's because that if they're born within 14 days of vaccine administration, the mother hasn't had enough time to develop the mature antibodies and then transfer it to the infant prior to their birth. And then, as I mentioned earlier, there are some infants who would benefit from a second RSV vaccine as they enter their second RSV season. And those are children who are classified as high risk for RSV morbidity. And specifically, those may include American Indian or Alaska Native children, children with chronic lung disease of prematurity who required medical support during the first 6 months, or children with severe immunocompromise or with severe cystic fibrosis. Otherwise, for most infants and children, they will not need a second dose of RSV during their second RSV season. For those infants who are receiving RSV monoclonal antibodies, they can receive it at birth during their hospitalization, or they can also receive it during their outpatient setting. If they were born during the active RSV season, it is recommended to administer the monoclonal antibody at least 1 week after their birth. And then just some highlights and new information to add on now that we do have additional data as we enter our second year of RSV season. The CDC most recently in their June ACIP meeting took a look at some safety surveillance data. And you can see that summarized on this slide where they looked at VAERS and VSafe information. But essentially for those pregnant women and infants born pregnant women who receive maternal RSV vaccination, they found the safety profile to be as expected. There were some low numbers of preterm births that were associated with the maternal Pfizer vaccine. However, those rates were equivalent to what we would typically see in the background rate. So at this time, there's no concern that that may be due to the vaccine. As more safety data is collected, the CDC and FDA will continue to monitor that and issue any subsequent recommendations. But at this time, from a safety profile standpoint, it looks like it's as expected and it is safe for our target population. The other thing to look at is our effectiveness of the vaccine products. It is important to note that the CDC did not have estimates available for maternal RSV vaccine during the last season, but they did have effectiveness data for nirsevimab, the monoclonal antibody. On this slide at the top in the blue, you'll see the data of the vaccine efficacy summarized from the clinical trials. And on the bottom 4 lines in the red, you'll see the data from observational studies over the first RSV season last year for the effectiveness against certain outcomes. And overall, what we're looking at is that the vaccine effectiveness from the observational studies and real-world use are pretty equivalent to the vaccine efficacy data that we saw in the clinical trials. So we see an efficacy or effectiveness anywhere from 79 to 90% in terms of preventing hospitalizations, ICU admissions, or lower respiratory tract infections. So we do see that the monoclonal antibody is working really well in the real world, and it's matching what we saw in the clinical trials. All right, so with that, I will pass it back to Dr. Silverman to continue his section.
All right, like being in a relay race. Okay, thank you. So I'm going to focus a little bit on some of these new tools that Dr. Dang has touched on and expand a lot about what we have available in pregnancy, since that's sort of the area I work in primarily. And what we've been talking about is this new vaccine that was developed, and I have no financial relationship with the company, but the Pfizer vaccine is the one that we are using for pregnant patients exclusively. And this was presented and reported in the New England Journal of Medicine a little over a year ago. And the important thing for us to keep in mind as we describe this vaccine for our patients is that this is based on a traditional vaccine platform. Not that I am saying anything against the new mRNA vaccine, but the COVID mRNA vaccines have become unnecessarily politicized in some corners. But we are back to a traditional protein-based vaccine platform for this RSV vaccine. And this, I tell people, is exactly the same platform that we use for hepatitis B vaccine. It's used for meningococcal vaccine. And this is a bivalent vaccine against 2 strains of RSV that was shown in this Matisse study, in a global study, to have an impact on preventing RSV vaccines in infants when given to pregnant patients. And just to give you a little bit of background on this study, the study was conducted and analyzed between June of 2020 and September of 2022. Women were initially enrolled for this study between 24 and 36 weeks of pregnancy, and overall about 7,300 and some mothers were enrolled in this study globally. So when we look at the primary endpoints for this study, we looked the authors looked both at severe lower respiratory tract disease in kids born after maternal vaccination, and then any RSV-related illness. Obviously, the severe illness in infants is what the primary outcome was intended to be. And when you look at this, and this is divided up into two groups. First, the initial group of all patients enrolled between 24 and 36 weeks, and then the subgroup, which represents the group that was finally approved for the vaccine administration, which wound up being between 32 and 36 weeks for reasons that we'll get to. But when you look at the overall group, this vaccine for the first 3 months after birth was 82% efficacious at preventing severe newborn illness. And while lower, the efficacy was close to 70% after that point up to 6 months after birth. In the narrower subgroup that was approved by the FDA and the CDC, the vaccine had 90% efficacy against severe illness in the first 3 months and 76% efficacy in the first 6 months after birth. When we look at any lower respiratory tract illness in infants whose mothers received vaccines, not surprisingly, its ability to prevent all confirmed illness was lower. In the first 3 months of life, it was about 57% efficacious, and that stayed pretty consistent through the first 6 months of life. In the narrower window, and people are reanalyzing this data, in the first 3 months of life, it was significantly lower, about 35%, but in the first 6 months after birth, about 57%, comparable to the larger group. The investigators also looked at adverse outcomes that may have been associated with maternal vaccination, both in the initial trial interval and in the approved dosing interval. And the preterm birth rate, although the background population risk for preterm birth in the United States is between 4 and 5%, so that the vaccinated group had a higher rate of preterm birth than the placebo group did in both intervals, but these were not statistically significant differences, and there's not really a clinically relevant difference between 5 and 6%. When we narrow it down to just the US preterm birth data in this trial, and the United States was the largest contributing country in the trial, just under half of all participants came from the US. That imbalance in preterm births was actually reversed, although still not statistically significant. So that in the trial interval, initially intention to treat 5.7 versus 5.3% and 4 to 4.4%. So even though the numbers vary a little bit, these are not statistically different in terms of the analysis. And as a result, the FDA and the CDC, when they analyzed these data, suggested, however, that the approved dosing interval be 32 to 36 weeks gestation, which is where it is now, and that is when we are vaccinating our pregnant patients. In terms of how the vaccine needs to get managed, and this is both for pharmacists and for providers on the call who hopefully have it in their offices to administer it on site. This is what the setup looks like. It's a single needle-free reconstitution kit, and the kit includes the lyophilized antigen in the small vial and a syringe of water diluent and a Luer lock adapter. You mix it up, redraw it back out into the syringe and administer it. And it can be stored as refrigeration from 2 to 8 degrees centigrade. It should not be frozen. And it should be administered either immediately, but it can be stored at room temperature after reconstitution for up to 4 hours. And once it is reconstituted, it should not be refrigerated if it isn't used right away, and the reconstituted vaccine, like the unreconstituted, should never be frozen. So when we look at the use of this vaccine during pregnancy, as Dr. Dang mentioned, it is intended as a one-time dose between 32 weeks and 36 and 6/7 weeks. So it's essentially up to 37 weeks gestation. And again, it's a seasonal, September to January in most of the United States, and it's designed for the prevention of illness for infants under the age up to 6 months of age. And I'm not going to repeat some of the other things here, though it can be, and ACOG has endorsed this as well as SMFM, that it can be simultaneously administered with other indicated vaccines, such as, and there are a lot of vaccines that may be given during a similar window, especially Tdap, which is given between 28 and 32 weeks, or ideally. Also influenza and COVID vaccines, because these are all respiratory seasonal vaccines. But you can give the RSV vaccine simultaneously with any of these other vaccines. And again, Richard did touch on this, but we really want to emphasize this fact that the only RSV vaccine that's approved for pregnancy is the Pfizer bivalent vaccine, Abrysvo. Again, we are not pushing this vaccine from a conflict of interest point of view, but this is the only one that has been studied. Arexvy, the GSK RSV vaccine, while fine for non-pregnant adults, older adults, it is not approved for use in pregnancy. Specifically, these data just came out a few months ago. The risk of preterm birth associated with the GSK RSV vaccine was significantly different in the vaccine group compared to the placebo group, and it was a 37% higher risk of preterm birth associated with that vaccine. And as Dr. Dang also alluded to, there will now be a third vaccine likely available for this upcoming fall RSV season for older adults, which is an mRNA vaccine that was put out by Moderna. And I think it is incumbent for us, if we are not administering it on site in our clinical areas, that when we send patients to get vaccines with one of our pharmacy colleagues, we are going to have to tell them that they have to get the Pfizer vaccine. We're in this unique situation where we have 3 different vaccines that are equally efficacious for prevention of RSV-related illness in non-pregnant older adults, and probably are equally efficacious for prevention of disease in infants, but only one has been fully studied and proven not to be detrimental potentially to pregnancies and newborns, and that is the Pfizer vaccine. So we are going to have to be cognizant of that, because there is now a third vaccine that can be given. So both we as providers and our pharmacy colleagues need to be really aware of making a distinction between vaccines for who we are vaccinating. We do our RSV vaccines on site at all of our outpatient areas in the UCLA health system, and we have made a decision to only stock the Pfizer vaccine, especially in areas like family practice outpatient areas where both pregnant patients and non-pregnant patients are seen, so that there is not the potential for mix-up in our outpatient areas for 2 different vaccines and a pregnant person getting one of the other 2 vaccines that are approved for adults. So these are things that I think people should think about as they stock. The other issue, and this, we started late on the RSV season last year because the vaccine was approved late and very close to the time that RSV season was actually starting. So we at UCLA, like many centers, really didn't get our vaccine in our hands until the second week of October. and we were playing catch up. And then at ACOG, we were constantly rewriting our guidelines for providers because new little glitches came out. One was about the fact that folks were not specifying which vaccine, and patients weren't saying they were pregnant. And two, that expiration of the vaccine was not really discussed, and we changed that in December in the guidelines when we wrote them. So in contrast to what we do with flu vaccines at the end of every season, because there's a new flu shot every year based on which strains of the influenza virus need to be put into each season's vaccine, we do not discard RSV vaccine at the end of each season, because the vaccine that people got last season is exactly the same as the one that they're going to be getting this season. And the vaccines that were unused from last season are good for at least an additional season. So you need to think forward about that as you stock for the coming season, that what you don't use now, you can use for the 2025-2026 season. So you don't have to under order worried that there's going to be leftover vaccine with RSV. You can use it next year. All right, I'm going to touch on neonatal therapy a little bit because this is also unique that we have options to vaccinate the mother or to passively immunize the newborn. There are risks and benefits to each of these approaches. For the RSV vaccine, one of the primary benefits is that newborn and infant, that kid is protected right after it's born. It may be a little bit more resistant this way to viral mutation, although RSV happily has not mutated, and it avoids the infant getting the injection, which parents sometimes don't like. The major risk is this potential risk of preterm birth, which so far in the initial Matisse trial, as well as in real life studies that have been put out, there are a couple of very good studies that have come out of Cornell looking at real life data and showed no increased risk of preterm birth in vaccinated mothers compared to unvaccinated mothers. Nirsevimab, the monoclonal antibody, may have protection antibody levels that wane a bit more slowly than those that are conferred to the infant through maternal vaccination. There's obviously no risk of adverse pregnancy outcomes. The big issue last year was that we had very limited availability of nirsevimab for that season. It's a little tougher to come up with and to produce. We are hoping that changes. Both approaches have been shown to be cost-effective, but these are the sort of base costs. The vaccine base cost is about $300. For the monoclonal antibody, the base cost is $500. And in terms of availability, we anticipate, and this was also brought out at the ACIP meeting in June, that we should have quantities of nirsevimab available for outpatient and inpatient pediatric areas by early October. So we have fingers crossed, and if not, we are going to have to start going back to pushing maternal vaccination. These are some real-world effectiveness data that were presented at the ACIP meeting in June, and you can see these are real-world data from Spain and France, and you can see the effectiveness of nirsevimab alone was well in the 80s to 90s in preventing RSV-associated hospitalization, as well as really high effectiveness for oxygen requirements and ICU admissions in newborns. And for any medically attended RSV infection, the effectiveness was still in the 75 to 80% range. So this is a good product as well if the mom has not been vaccinated or if the mom has not been vaccinated. So what barriers do we still have? This is just to show you that despite the rollout, this is looking at older adults, only about 22% of eligible older adults over the age of 60 got RSV vaccine last season. And when we look at pregnant patients, the overall rate, and this is stratified by race ethnicity, but the overall rate is this one here in the orange, is about 18% of eligible pregnant patients in the United States this past season. Only that many got vaccinated against RSV. When you look at the data and whether vaccinations had an impact on RSV rates, it did, surprisingly, with only 20% of pregnant patients being vaccinated. When we look at kids under a year of age from last RSV season, this large high green peak is from 2022 to 2023, and this red peak is last season. So the rates of RSV hospitalizations in infants was still cut, but imagine how much lower we could bring it if we get more of our moms vaccinated. So this is something that we need to work on, but this sort of shows us in real world data that the vaccine does help. And just to give you, we're not doing any better with other vaccines. This is from the CDC that was just published earlier this year. But as the pandemic progressed, we got worse and worse at vaccinating our pregnant patients during respiratory season. With this past season, only 36% of eligible pregnant patients got a flu shot. So it's not just RSV, but we all need to do better at vaccinating folks. All right, and then lastly, I'm just going to touch on the question of revaccination of pregnant people during subsequent pregnancies. As Dr. Dang mentioned, there's still no data on additional RSV vaccine doses in subsequent pregnancy. The big question I am getting is if a pregnant patient got an RSV vaccine during the last season and she is now pregnant and would be eligible, do we vaccinate her during this coming season? Happily, that is a minority of patients, because we don't like that short interval pregnancy in general, because it's associated with higher perinatal risks, specifically higher rates of preterm birth and higher rates of fetal growth restriction, but it happens. We also know that the data that have just come out earlier this year from older adults vaccination, where they did study vaccination 2 seasons in a row in older adults, and this second shot actually didn't do anything to antibody levels. In fact, the levels were higher before people got the second shot than after they got the second shot in that population. And even though we give Tdap in every pregnancy, there are still some safety concerns with this being a newer vaccine. And we don't know whether additional subsequent doses of vaccine will add to a preterm birth risk. So right now, and an alternate product being nirsevimab does exist that can protect infants very well. So right now, the current recommendations from the CDC are that people who received a maternal RSV vaccine during a previous pregnancy should not get additional doses during future pregnancies. And as more seasons pass, that may change. We may decide that there's an appropriate interval where that pregnant patient should get another RSV vaccine after 2 years or after 3 years. We just don't have that yet. And infants who were born to people who were vaccinated during a prior pregnancy should get nirsevimab, ideally as soon as after birth as possible. So I will stop there and give it back to Dr. Dang to sum up.
All right, thank you. So we'll move on to this last section here where we can talk about opportunities for collaboration. So just to kind of take a look at some of the data and take a look at the opportunities as well. So for this slide here, CDC did a study over the last year to determine where individuals were receiving their vaccinations. So you can see on this slide the data for RSV vaccines in older adults, COVID-19 vaccine and influenza vaccines, and the locations in which they received their vaccinations. Generally speaking, pharmacies or drugstores were the primary locations for all three of the vaccines where individuals were receiving their vaccinations. And the second primary locations being at physician offices, and third being at hospitals or clinics and health centers. And so when we look at this data, I think these are the key partners that have really great opportunities for collaboration to help increase vaccination rates across the ecosystem. And when we're thinking about capacity, each provider type has a set capacity that it can individually handle. So I think when we involve more players, we can have greater numbers of individuals vaccinated through all of the different available channels. Now, specific to maternal RSV vaccination, CDC did look at some data there as well. And based on both IQVIA and national survey data, for maternal RSV vaccines, the primary location was actually in physician medical offices and not in pharmacies. And that does make a lot of sense based on where the recommendations are coming from either their OBGYNs or their primary care providers who may be making those recommendations for their vaccinations during pregnancy. It may also have to do with some of the coverage issues of where the vaccine is covered based on that patient's specific health plans. But along with that, it does again highlight the opportunities for collaboration between physician offices, pharmacies, hospitals, and public health. I think when we take a look at some of the patient-centered opportunities, these are all the different things to consider for increasing vaccination rates. One is a strong provider recommendation to receive the vaccine. Study after study has shown that is one of the most influential factors for patients deciding to receive a vaccine is when you have a strong recommendation from the provider that they're seeing and that they trust. Second is incorporating direct referrals and handoff of patients with intentful collaboration and coordination. So for example, if there is a patient who was identified by an OBGYN's office to benefit from maternal RSV vaccine, but they may not carry it or have it available, having a direct referral to a local pharmacy that does have the vaccine available would be beneficial in increasing the likelihood that the patient would receive that vaccination. And then from there, having shared documentation to increase communication will be helpful as well. Communication from the pharmacy back to the OB's office or the PCP's office as far as what was administered, or vice versa as far as what is being recommended, to make sure that we have a complete medical record so that each key stakeholder is aware of what is going on. And that ensures that we have a cohesive immunization neighborhood. So for both of our pharmacy and physician colleagues who are on this call, we encourage you to take a look at some of your collaboration opportunities that are available to you. Take a look at where some of the local pharmacies or medical practices are to see if you can create a conversation on how this referral process would work to ensure that patients are receiving the vaccinations that they need. And then I'll wrap with just some highlights of information about what pharmacists can do. And this may be a newer space for some individuals if you haven't been keeping up with what's been happening. But in California specifically, because pharmacy scope of practice is variable based on state law. So specifically in California, pharmacists can independently prescribe any FDA or CDC recommended vaccine for all individuals aged 3 years and older. So for my pharmacy colleagues, you can initiate a prescription for RSV vaccine to a pregnant woman if she meets the recommendations for the appropriate weeks of gestation and the months of the year. Additionally, pharmacists can furnish a prescription for any vaccine for any patient of any age under a collaborative practice agreement. And so that would be in direct partnership with a physician partner. Additionally, pharmacists in California can independently administer any FDA and CDC vaccine for all individuals age years 3 and older. So again, for pharmacy colleagues, you can vaccinate our pregnant women who are indicated to receive an RSV vaccine if they show up to your pharmacy. Additionally, pharmacists may administer a drug or biological product pursuant to a prescriber order. And I included that because that does indicate that pharmacists can also administer nirsevimab or the monoclonal antibody if there is a prescription from the patient's prescriber. So that wraps our information here, and I'll pass it back to Dr. Ball and Dr. Pannaraj for the next section.
Great. Thank you so much to both Dr. Silverman and Dr. Dang for your presentations. This was very helpful. I especially enjoyed hearing about how important it is for all of these collaborations between the OB provider, the primary care provider, and the pharmacy. And I actually want to introduce Kelsey Florio, who is going to talk about one more potential area of collaboration, and that is the birth hospitals for the delivery of nirsevimab. So Kelsey works for the California Department of Public Health. She is an immunization branch vaccine nurse consultant. She provides immunization technical assistance and consultation to VFC and COVID-19 vaccine providers and local health jurisdiction staff. And so today, or currently, her focus is to enroll birthing hospitals in VFC. I'll turn it over to her.
Hi, everyone. Thank you. Next slide, please. So I'm going to start with an introduction to what VFC is in case you're not familiar with the program. It's federally funded, and it provides all ACIP recommended vaccines at no cost to participating healthcare providers. Eligible children are entitled to receive all ACIP recommended vaccines through VFC, and in California, over 50% of children under 19 years of age are eligible to receive VFC supplied vaccines. And so RSV and hepatitis B vaccines are uniquely available to be ordered, just those two, for birthing hospitals. And I'm going to talk a little bit about how we're trying to enroll them in the program. Next slide. So in 2023-2024, there were 238 hospitals with birthing services, but 174 were not enrolled in VFC. And as a result, only about 5% of the total nirsevimab doses were administered in hospitals to those newborns. Next slide. Our goal this year is to enroll the top 50 birthing hospitals into VFC, and by top 50, we looked at the populations of the patients that they serve and deliver to prioritize them into that top 50. And ultimately, our long-term goal is to enroll all 174 birthing hospitals so they can receive those no-cost immunizations. Next slide. This is a look at where those top 50 hospitals lay throughout California. Next slide. And here is where we're at currently. So as you can see in our green circle all the way on the right, 10 have applied, which is fantastic. And then looking to the left, 6 committed to apply but haven't applied yet. And then we have 22 that are still interested in applying, but we're not seeing any applications. Next slide, please. So we're asking you, if you're working for a birthing hospital, if you have partners at birthing hospitals, please, please, please encourage them to enroll in VFC. You can explain to them how important it is that nirsevimab be administered to that newborn within the first 7 days of life. And so why at delivery, that is a great time to administer this immunization. We all know that sometimes parents cannot bring their newborn into the doctor's office within that first 7 days of life. So it's critical that these hospitals are able to get access to these no-cost immunizations and administer them. So to refer the hospitals, thank you. To refer the hospitals, please send them to vfc-enrollment@cdph.ca.gov. We also have this handy job aid that CDC provided talking about the benefits for hospitals. And then on the next slide, you can also share with them every Wednesday at 1:30, we have an enrollment seminar that they can learn about enrolling in VFC. And then next slide. Also, there is a grant that CDPH is currently publicizing. We've heard from many hospitals that they are struggling with updating their EHR it's a big ask. It requires a lot of staffing and a lot of funding. So this grant we think would be excellent to be used for that purpose. Next slide. And then Finally, I just wanted to talk about how you can prepare for the upcoming RSV season if you are a clinic that might be offering nirsevimab. It's important to take a look now at your patient population, who's going to be eligible based on the eligibility criteria that Dr. Dang and Dr. Silverman talked about. Place your orders now. The VFC deadline for the first round of ordering for nirsevimab is tomorrow. And then plan, you're going to have more immunizations this year maybe than last year. So how are you going to immunize with RSV, COVID, and flu during this respiratory season? Next slide, please. Next slide. And lastly, I just wanted to provide my contact information, and then once again at the bottom of the screen, the enrollment email. So thank you so much for having me today.
Thanks so much, Kelsey. That was excellent. We have several opportunities to vaccinate these families to protect these children against RSV in the prenatal period, like we talked about today, as well as in the hospital, and then in the family doc or pediatrician's office after birth. So this is a great opportunity to be able to get another chance to give these children nirsevimab early on. So thanks so much for that presentation. We have time for like 1 or 2 questions with Dr. Dang and Dr. Silverman. So if you guys want to turn your cameras back on. And I want to take a question from the Q&A for Dr. Silverman. Why is the cutoff at 36 weeks? Most people are delivering, ideally around 40 weeks or so. So why, if you have someone who's at 37 or 38 weeks, should you not give them an RSV vaccine?
It's just that when you look statistically at the rates of birth by the time someone is 40 weeks, you don't want to vaccinate them with taking the chance that they won't deliver until 40 weeks. So it's actually not 36 weeks. It's 36 and 6/7 weeks. So technically you're taking it up to 37 weeks, which means that that gives someone up till 39 weeks to deliver. And the majority of people will deliver from 38 weeks onward. And once you get to 40 weeks, there's less. So don't think of it in terms of 36 weeks. We're not allowed to say 37 weeks because it's technically not 37 weeks, but it's 36 and 6/7 weeks. But for all intents and purposes, if someone is 37 weeks and in your clinic, you should vaccinate them. You can still do it because that one day is not going to make a difference. But we don't want people being vaccinated at 39 weeks because it's unlikely that vaccine is going to do the kid any good, and that child is better off getting nirsevimab. So hopefully that answers the question.
I have a quick question about how you approach the shared decision-making with the family when the mom is in your office. I know you listed out the pros and cons, but practically speaking, when they're sitting there, what do you say? And then from the pharmacy side, is that possible in the pharmacy as well? In 1 minute.
Yeah. The short answer is yes. We have to talk about both options. I will tell you that when I see people in our outpatient clinic, I will push the vaccine because they're there in front of me. And if they're in the window, I want them to get the vaccine before they leave the office. And I'm usually pretty successful. And if they resist, I would tell them to consider getting the baby nirsevimab as soon as possible after it's born. Richard? From a pharmacy point of view, I mean, by the time, I don't know how often the pharmacist will actually get that kind of question. What should I do? Should I get this vaccine now that I'm here? I would just say, you're here, get the darn vaccine already.
Yeah, I agree. If they're in front of you, if they're indicated for it, we should recommend that they get it. Yeah.
Perfect. Thank you so much to both of you. As I close, I also want to remind any AAP members on board that the votes for district chair, The email will go out tomorrow, so please remember to vote. You have two options. One is my co-moderator, Eric Ball, who has been an excellent service member for our community in California, and he is running against Alice Kuo from UCLA. So please remember to vote when you get that email tomorrow. So again, thank you both, Dr. Silverman, Dr. Dang, and actually also to Kelsey for your presentations and for enlightening us some more about maternal vaccines. Please remember to get your patients vaccinated, and also don't forget about flu and COVID vaccines, which are also out now. These slides will be posted on the California Immunization Coalition website and on YouTube. So please feel free to share that with any colleagues who could not attend today. So thank you very much and have a good rest of the afternoon.
Thanks all.